Nice.
Hey guys, Chelsea and Chance here with you today. We are going to discuss documentation. I will just quickly say that the views expressed by myself and Chance are of our own and not a reflection of his institution or place of employment. I'm so glad you're here, Chance. Welcome.
Thank you. Thank you for having me. It's I'm super excited to be here. This is a really cool thing that you have going on, especially for the community. I think it's an awesome opportunity to get on here and talk about something that's maybe a little off topic in terms of being an interesting thing. So we'll go with it.
For sure. So I feel like we all can expand on our knowledge of documentation and improve our documentation. As we've all heard it, CYA. If it doesn't happen, if you didn't document it, it didn't happen. If it didn't happen, you don't document it. So that's something that's totally grilled into us. You have some great experience. You were in veterinary medicine, which I assume you do similar documentation, but not quite to the extent of nursing. And then you completed your nursing degree in 2015, your master's in 2020. You've got a lot of experience in various ways, but a lot of it you're doing education, which fits totally with what we've got going on, and I'm really excited to learn from you. So with all of that said, do you have anything you would like to add to your introduction?
Man, not really. I think I'll say it this way. I think that when it comes to documentation, I think the reason that there's a lot of unknowns is that because documentation is really poorly covered in nursing school. It's poorly trained upon in the hospital. I see it every day. And so unless you're making active kind of personal efforts to improve documentation, that's kind of one of the reasons why. And one of the reasons I think, and I may be jumping the gun a little bit, I started thinking about this a little bit last night. It's like, why, like, what is the real purpose of the website? And really that goes to, I think that if you start to Google anything about documentation, what happens is you're sent in like 50 different directions. So you'll get one news article or one bit of information, or you'll get one blog post or one really well written blog post, and then one that's poorly written, and they don't really provide a lot of guidance. And so my idea is to kind of somewhat filter through that, and then also provide a comprehensive resource that if everybody goes, I have a question about documentation, where can I go find something that at least points me in the right direction? Maybe they're not going to give me an answer, but they're going to send me in the right direction to where I can ask the right questions. And that's really kind of the purpose of the website. And so, building this, I had another one up for a while, and that was easy to build because it was all philosophical and it was great and it was easy and came together really, really easily. This one was a lot more challenging because I wanted to make sure that it was truly meaningful, and that's kind of the gist behind why I started Mynursingnote.com. So
perfect. So I actually didn't cover that. Chance recently started MyNursingNote.com. It's really just, like you were saying, an all-inclusive resource to teach you what it is that maybe you haven't already learned, or maybe you need some expounding knowledge so that you can continue growing in your strength of documentation, which is so important to cover our buns. All right, so I know you have them. I always like to start out with an icebreaker, and this one's perfect because we all have come across really funny nursing documentation bloopers. What's your favorite?
So I don't know if I have a particular favorite, and I thought about this because we had talked about it a little bit, and obviously I'm not going to violate HIPAA.
No,
but the ones that always made me laugh the most were the ones where the patient, like the nurse, felt so compelled to write whatever colorful words that the patient used to describe them. I had my own share. Yeah, patient stated, quote, F this, blah, 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 blah. And that's just the way it rolls, right? And those always got me because I would get some little meemaw who was having sundowning. She was either sundowning, or I had patients that ICU delirium, and they were, patient proceeded to kick me in the head. Like I wrote that one time. I had a patient that he was he had some mental status changes and rolled in from a different floor, and he quickly got 4-point restraints. But when you're trying to abuse nurses, that's usually what happens until we can get you settled down. And man, that was just those were really kind of the ones that always made me chuckle. Was that patient stated and they went on. The ones that were always, I think, from like a provider standpoint, that made me kind of question what I was doing, was the ones where, and I'm guilty of this, when you get in such a hurry, you misspell something. Oh, yeah. And so like the patient was under anesthesia. You're like, nope, no, they weren't. This is not Fantasia. This is not a Disney movie. Those are always kind of the ones. Some misspellings were worse than others, but those are the ones that always kind of got me laughing, because I would spend the time to go read the nursing note, or even the progress notes from the providers. So that's really kind of the ones that always made me laugh.
That's awesome. So when did you realize you had a passion for helping our profession improve our documentation process?
It actually, I think, goes back to really veterinary medicine. The challenges, and you kind of brought this up, was that there's a huge amount of we were talking about this before we went live, was there are over like 500 different electronic health record companies, like Allscripts, Epic, Meditech, Dr. Chrono, Cerner, all of these, and they all have like a particular purpose. And what happens when you get into like the medical documentation side in veterinary medicine, it's very archaic. One of the longest jobs that I had in general practice, because if you know anything about veterinary medicine, most techs don't stay around for a while. You're usually bouncing from job to job. It's just kind of the nature of the beast. Is that one of the jobs that I had was, they were almost like an MS-DOS based program. So everything was numbers. I can still remember 4410 was the biohazard code. That was always 44.10, and everything was 10 key. And that's not a really good way to document. And then you would fall back on this idea of, that was right about the time all these electronic health records were coming out, and everybody was translating from like a handwritten service to it was difficult, because he's a friend of mine now. He takes care of my animals. I'll call him up and we talk all the time just about random stuff. But then I remember they would have to bring me his records, because I was the only one that could read his handwriting. And as you progress through that, you're going to come across all these different things. And I finally got it. I became a nurse, and I got into the side of electronic health records. And that's really what kind of drove it. And I was like, okay, cool. This is everything is, I'm using a particular EHR, and I'm working through, a particular workflow. And then I did that for a couple of years. And then I went to work as a community health nurse at a college, and they had a charter high school. Everything was handwritten notes. There were no templates. It was a blank sheet of paper with lines. And it drove me nuts, because I was like, there is no system. And I kept pushing. I was like, EHR. And they're like, no, we don't have the money to do it. And I'm like, you guys are killing me. I'm like, I'm spending way too much time documenting. Because in that particular role, like, some were easy. Patient presents for headache, over-the-counter aspirin given, etc. Because we had standing orders for those. But then there would be the ones where that particular role, I had to be the first responder on the entire campus. So I'm going to go see this person who may or may not have been a frequent flyer in the health center. I have no medical history on this. I've got no emergency contacts. I've got no way to communicate with anybody. And I'm basically showing up blind. And then I get back and I have to remember everything that happened. And it was such a challenge. And so as I went into this, and then in the previous job I had, if anybody looks me up on LinkedIn, they'll know I worked for nursing.com. And when I was there, one of the courses I just happened to teach was documentation. And so with that, it was, really nailing down kind of the important facets of documentation. But it really comes down to, as a profession, especially now that I'm seeing kind of the impact that it has on the community, is that we need to make sure that we are, kind of from the tried our end standpoint is we need to protect our profession. We need to protect our licenses, but at the same time, we need to protect our organizations that provide us jobs. And most importantly, we need to provide transparency and adequate communication across a care team to patients.
Mm-hmm.
And if you don't know how to document, even if it's I'm working in this EHR or I don't know how to document in general, we're creating barriers and trying to break those barriers down through that process. Like that's kind of how we get there. But I've always had this really quirky interest in documentation and medical terminology. So I was like, I would read pathology reports and be like, what does it mean? And so like, but that's just the way my brain, like in my family would be like, I got this thing back from the doctor. Will you read it? And I'm like, okay. So I'll go through it. That's fine. But that's really, I've always just had this knack for really kind of digging into the linguistics of medicine. And so like, that's why I kind of got into it. And then I was like, oh, I really enjoyed doing this and teaching it. So why not start a website to talk and give people a resource?
That's awesome. So let's get into the nuts and bolts and why people were so interested in hearing this talk. I know for a fact, they want to know, what do I chart and what do I not chart? So can we start off with the 5 key pointers for documentation?
Yeah. So I'll give you, there's a lot.
You can do more than 5 if you want. I was just giving us a starting point.
Yeah. So let's think about documentation this way. So anytime I teach or I do education, I always like to kind of bring up some sort of analogy. And the way I like to think about documentation is to kind of think in terms of Bob Ross. Bob Ross is like one of my favorite all-time artists. I love happy trees and there are no mistakes, only happy accidents. And that's just my thing. Like I even have a Bob Ross Deadpool.
That's awesome.
I love this thing. I'm a huge Deadpool fan, huge Bob Ross fan. And that's kind of like my kids got that for me for Christmas. But so Bob Ross, he, as an artist, like it really was, I have a giant canvas and I have all of my paints and I have my paintbrushes. And the challenge is I'm going to paint a picture. And with documentation, it's about improving your craft as an art. Don't ever think about documentation as fitting inside a box, because sure enough, there's going to be a situation where it doesn't. Mm-hmm. And that's where you start kind of where you get away from the idea of, I have to document X, Y, and Z. And that particular patient sues the hospital, files a complaint. Now you're in court and you have to back up your documentation. So your documentation generally has to paint a picture of what is going on with your patient at any given time, so that number one, it's clear, it's communicated effectively across the entire team, no matter if it's an RT, whether it's a unit coordinator, whether it's a manager, whether it's leadership, whatever. Anybody can look at a chart at any time, any one of your charts, and understand what's going on with the patient. Mm-hmm. And that's kind of like the general context. And if you kind of apply that generally to your documentation, is there something missing that I haven't said or haven't spoken about, or hasn't been documented somewhere? Where should I put it? So think of like the electronic health record being Bob Ross's canvas, and then his paints and his paintbrushes as being kind of the tools and features of that electronic health record. And I'm just going to use those to paint this picture. So if you think about your documentation in that context, I think it kind of sets you up on this platform to be successful. That is not really a key pointer, but I think having that mindset and that philosophy going into documentation, I think that you can actually set yourself up for success. In terms of pointers, the first one is knowing your Nurse Practice Act. This is so very important, because your Nursing Practice Act will actually help you to understand what you should be documenting, because you should know what falls within an NPA so that you know what you are allowed to do. For instance, I think it's like South Carolina. you're not allowed to remove like arterial lines.
Oh.
It's one of those weird nuanced things, right? I don't know. I'll say sheath, because sheath is probably like in my clinical rotation in ICU, they let me pull a sheath, but when I went to my RN, I'm working independently under my own license, that the hospital did not let nurses pull sheaths. And so, like, think about it in that context. Am I removing a line that I'm allowed to remove? Am I putting in a line that I am allowed to put in? And really, that's driven by the Nurse Practice Act. And if your Nurse Practice Act says that you can or cannot do certain things, knowing that and having that documentation, because if you write that down and you say, I did this stuff for this patient, and they say, okay, did you have an order? And do you have the legal responsibility to do those two things? Then you should be covered. And that's where the whole Bob Ross thing comes in, because it becomes this, did I create a clear enough picture of what that was? So the first one is knowing your Nurse Practice Act. I sent you this message, like, I think it was earlier this week or this weekend. I was like, look at this thing I did. It's super cool. So on the website, if you go to mynursingnote.com/resources, there is a map. And if you go to that map and you find your state and you click on your state, it will take you directly to your Nurse Practice Act. That works only on desktop. If you're on mobile, you can actually click the drop down. But I've made that available for everybody that's practicing. So wherever you're practicing, go to that website and find out what it is. Also, if a link is broken, it doesn't work, please let me know so I can fix it.
You know what I loved about that, Chance? I went in, after you messaged me, I went in and I kind of navigated that. Mm-hmm. As a traveler, when I traveled for 4.5 years, and that would have been so helpful to have a one-stop shop to look at my Nursing Practice Act for the next state that I was going to be in, because little things do change, and it's really important that you know what you're able to be doing, because it really is your responsibility. And sometimes we kind of expect that we're going to get that on orientation, but specifically in the travel industry, you get 3 days of orientation. You're not going to learn everything you can and can't do. It's on you. So I really like that you put that up there, and I'm definitely going to reference that whenever people ask about traveling and that sort of thing, because it's important.
Yeah, I don't even know how I made it happen, but I did. I was like, this thing, it works. It's so cool. I was so excited. But there are websites that have it. The problem that I found with them was that in those websites, it was kind of a 2 or 3 extra clicks, and you had to kind of know which one. Like some are like rules and regulations, and then one's like the Nurse Practice Act. But like Nurse Practice Act really stipulates like more from like a legal law standpoint. Like what has the legislature said that I can and can't do versus like, and I'm getting into a little bit of legalese here. So disclaimer, I'm not a lawyer in any way. Should anything be construed as legal advice? That's my disclaimer. Yeah. But if you go on the nurse, like understanding the difference between a Nurse Practice Act and the rules and regulations. So like Texas, for instance, I'll speak as a Texas nurse practicing under my own license. There are rules that are there have been, I recently got the Gazette, and it was like, here are the rules and regulation changes. Okay, cool. Those are rules and regulations that are made by the board. That is different than legislation that has been passed. Like if they say you have to, according to this, session of the Texas Congress, you have to have been a registered nurse for 5 years before you can do something, but the Board of Nursing says otherwise, it's going to fall back on the Nurse Practice Act. And the Nurse Practice Act is it's more specific as to what you can do. So just follow that. Like that's always in every like legal blog and every legal nursing consultant, they'll always tell you to follow your Nurse Practice Act. So if you set that kind of as like your reference for what you should, number one, what you should be doing, and number two, what you should be documenting, because there are actually sections in some of the NPAs that will actually tell you what you should be documenting, which is nice. But I didn't look through all 50 because I'm not a lawyer, and that's a lot of stuff.
All right.
That's number one. So the next one I'll say is familiarizing yourself with the software. So whatever electronic health record you're using, At some point, you should receive some training. I like formal training because I'm a formal trainer. And if you have people who know what they're doing in terms of training, like they should be setting you up to be successful in those roles because they should have like objectives and outcomes that are set. Other times, especially like you were talking about with travelers, I got 3 days of training. I got 2 days orientation. I got 1 day of XYZ software. If they have training environments for you to be in, by all means, take advantage of those.
Yeah.
And because most of those they'll break and then you reset them. But understanding how to navigate through the any sort of workflows or hey, this is how we get patients. Like when I was in SI or surgical trauma ICU, when I got my patients, I picked my patients. I would go to a roundtable report and I would pick my 2 patients. In other ICUs, they would just tell you which one you have.
Right.
And so, which was great because I had some control, unless you showed up late and then you just got the leftovers and then that was a bad day. But that really kind of helps you to understand how difficult your charting is going to be, because I have the Nurse Practice Act as a reference, but I also have the limitations of the software that I'm either aware of or I'm not aware of. And I need to know where I should document X, Y, and Z. That's really kind of the next pointer. The other one is, I'm going to say this and I'm probably going to get a lot of grief for it, but charting is close to the time that you actually document is a good pointer. Is it realistic? Not all the time. And I think that's the challenge. So there was there's a news article on the website. There's a news section, and what I do is I post relevant documentation, like news articles. And the one that happened was there was actually I'm trying to remember the case specifically, but they could not validate something that happened because the nurse took too long to do something or to document that care. So like we had, at least when I was on the unit, 24 hours to document inside a chart. So like, and I think that's reasonable. The problem is the integrity of your memory gets questioned. So if something happens to the patient, and let's say you discontinue the restraints and then they accidentally pull the tube out, well, what time did you really do it? Especially if you're actually documenting 16 hours later. Yeah. So I think there's a level of reasonableness that is kind of assumed by courts and cases, and
different institutions have different windows for reasonable time frame. So some, like your meds, have to be documented within 30 minutes. And now that's kind of out the window too with EMR, and you're scanning while you're administering. So that kind of, most of that gray area has shifted to non-existent. But in terms of documenting your cares and your hands-on, your assessments, those sorts of things, I know every institution I've ever worked in had a set time frame that was acceptable.
Yeah, like for instance, like my level 1, I'll never forget, because it was an internal decapitation. Okay. My first level 1. Not very many people have seen them. It was my first level 1 on my own. And I was in that room at least for 6 hours. Yeah. And I know that I didn't chart on stuff for 3 or 4, but I had something called a time tape, which is basically a piece of paper that has all my times. And I literally wrote everything down as I did them. Yeah. The challenge that I had was that if that case was ever brought to court, I would think that there would be, again, not a lawyer, there's a level of understanding when it comes to the ability for somebody to actually chart something versus the time they actually care for the patient. So I could see myself being under oath and saying, they're like, oh, hey, why didn't you document care on this patient at this time? Oh, because my other patient was actively trying to die.
But do you remember that? Because they can pull you. So say you're not working there anymore. They can still pull the patient's chart. It goes to court and they say, let's bring in Chance Reaves. And all of a sudden you're standing beside your charting. That's all you have to go by. And let's be honest, I don't remember every patient I ever cared for. And I definitely don't remember what happened to Mr. Sam when, Mr. So-and-so was over here trying to die. I don't remember him. He does not stick out because he was not important at the moment. Let's be real. Like, it's the whole scheme of things where when you're charting, I used to use the window because the window was right there in our ICU, and I had a dry erase marker, and I would write on my window, and I would sit right outside the room and document everything what happened. But that window charting is clearly not a usable document if it went to court. And they look at my charting and say, wait a second, you charted this at 1859, but it happened at 10:53 in the morning. And you're like, well, they were actively dying for 6 hours, 8 hours, and I just got an opportunity to sit down and chart my window charting. But when it's 5 years later, you don't remember if you just kind of guesstimated at that time frame. You can best
and I think that's kind of the reasonableness, right? There's another article in there in the news section, and there was this case where this pediatric, I forget how old they were, pediatric patient comes into the OR or the ER, they come in the ER, and they're complaining of like dehydration, nausea, vomiting. No, I can't remember if there's a fever or not. And the nurse sees them, does an assessment, and says, hey, look, something's wrong. The first provider comes in, sends them home for dehydration. They come back, same symptoms. The only thing that saved that institution was the fact that the nurse documented a neurologic assessment on that patient. The providers didn't document it, but that nurse did, and that saved the organization to say that the patient was actually assessed by a clinical provider. And so like, that's why it's important. Like, even if it's not at the minute, I know that like nursing school, they hammer this in, like, you need to document your meds when you, okay, great. Sure. I'll try. But if they're seizing and I didn't scan because I used my sick patient rights to verify that I was giving them Ativan and the provider was there and told me the dose they wanted, sure, I'm gonna give it. And that's why, again, it's Bob Ross-esque. So it's very much like I have to try to paint this picture as clearly as I can, as close to the time that I need to. So that's really kind of that pointer. The other kind of along that vein is charting habitually. And what I mean is that always chart your care for patients the same way. Because what you do is you improve efficiency, and by doing that, you make sure that you're not really missing anything. The biggest struggle I see with nurses when I'm training them in the EHR that we use is that I don't understand this bit, or it takes me a long time to doc. Like, I had a conversation with one of the nurses who was actually in this group. But she was actually in this group. I found out she worked at our hospital. I called her out. We did a WebEx. We went through it. Super cool. Anyway, so she's telling me that there was this one part that was becoming that was just slowing her down. And I said, look, let's try to figure out some way to make this faster. And I think we got to that point. But working that bit into every day I walk in, I review the Cardex, I review allergies, I do this stuff, and I do it the same way every time, means that when you actually forget to do something, you're going to feel off. And it's going to feel weird, and you're going to then dig in to find out what's missing. I will say, don't confuse habits with complacency. So what I mean by that is, don't say that you're reviewing meds or reviewing allergies and just click or select it or type it in and not actually do it. Because, oh, hey, I need to document that I did that. Now you're falsifying documentation, because now we're getting ourselves into trouble. But by creating habits, you improve efficiency, and that's really kind of the goal.
Yeah, I used to teach when I'd precept, I would teach systematic approach to our care, right? And so when we would come in, we would always do the same order of positioning, for all of our patients. So everyone started on their left side and then went to their right and then went supine. There would be a few cases, of course, that, patient in room 5 can only be on their right and supine, can't tolerate left. Okay, fair enough. But that's an exception to the rule, not the rule. So if you're creating these systems and you always change your tubing between this hour and this hour, when you get called into court years down the road, that this is the way you did things and that there were some exceptions to the rule, because there always are, but you would have documented those things differently, and it just makes your life so much easier.
Right. So there's a phrase, correlation does not equal causation. But I think in the courts of law, it gets a little bit, if you look at all of the other documents that I've ever made on any other patient, I always did this, this, and this, and this. There should have been a reason for this. And usually there's a reason to point to that. So that's a really good point, because creating those habits, you are going to create that pattern that allows you to feel better supported in a court case. I will also say, let me make this kind of stunning. It's a huge number, right? So there are, I forget the exact number of trillions of dollars spent in healthcare every year. When I say trillion is a lot. Let's say, I think it's like $3 trillion spent in healthcare. Only about 2 billion is spent in litigation. It's like 0.03%. It's still a ton of money, but still, of all of the associated healthcare costs, we're talking it's like less than 0.3%. So it's a small fraction. So don't think that if you don't document something, you're automatically going to get called into court.
Oh, sure.
But you could be in trouble by having a fallout and reporting, and then your manager talks to you. But systematically, there's reasons why these things happen. So, but creating those good habits is really kind of the gold standard. And then the last probably pointer I have is following your unit or organization standards. I will say that standards generally don't exist. And I think that's a problem. That one of the reasons I'm kind of deep diving into all of this is that a lot of times standards don't exist. And some standards that are created in hospitals or on units is a byproduct of either a root cause analysis or it's a reactionary process. Something has happened to a patient, and we need to make sure that we are CYAing our organization as a whole. Therefore, we are going to, in this unit, because it's more likely, we're going to make sure that we're documenting this particular thing of care. The challenge is that it doesn't become a standard. And then if you don't know about it, if you're a traveler and you're only there for 13 weeks, you got to make sure somebody's going to tell you. And if it's one of those really nuanced things, here's an example. Naloxone. We had a patient who came back, wasn't my patient. I was what they call a procedure nurse, where you're kind of on the unit and you're just helping other nurses. Patient comes back from OR. All of a sudden, he goes into almost respiratory distress. Okay. And I went and got the attending. They were in the call room, got the attending at bedside. She goes, let's do naloxone. So we pull naloxone. I give it. And then all of a sudden, my manager rolls in and she's like, what'd you guys give? We're like, naloxone? And she's like, okay, you have to do a safety post and we have to call the naloxone committee and we have to do blah, blah, blah. I'm like, what?
Wow.
Because as a reactionary process to naloxone being handed out like candy over a general period of time, they started a committee that reviewed every naloxone administration. It's a reactionary process.
Yeah.
I didn't know that, and I had been probably practicing on my own for 6 months. I didn't know that. So that's why following those standards is really important. And if they don't have standards, find out why and just try to say, what do people normally do and why do they document it a certain way? And if people, and we'll start to get into some of the don'ts, but if for whatever reason they tell you to do something that you know to be patently absurd or you know is going to get you in legal trouble, don't do it, because you're still responsible. You're responsible for your care. You're responsible for your documentation. And I don't care if I have a job or not. I can get another job. I can't get another license.
Yeah. For instance, every 2 hours in one of the ICUs I worked in, we were supposed to chart the full assessment, but they were just copying their initial assessment on every 2 hours. And I was like, no, do that. Why would you do that? A, there's a record that you simply copied and pasted. B, you should be charting by exception. If nothing changed, you state that nothing changed. There should be some way for you to document that.
Oh my goodness.
With efficiency, right? And I got called into my manager's office on more than one occasion, and I stood my ground and said, look, this is really poor practice, and I'm not going to do it. So with that said, you do what you want. I brought my evidence with me, and I stood my ground and said, I'm not doing that. And they never wrote me up or anything, but I did get talked to on more than one occasion. And that's just something you have to know your Nursing Practice Act, because like you said, there's a reactionary process. And sometimes when people don't know to say, I'm not doing that, then it just trickles down and everybody teaches everybody to do absurd things.
Yeah. Like, that's a key don't ever copy paste. Never do it. Yeah. Don't do it. It's so bad, because inevitably this goes back to creating good habits. Copying and pasting is a bad habit. You shouldn't do it because you will miss something.
Yep.
And there's also that record, like you talked about, especially with a lot of EHRs now. They are very meticulous in their tracking and auditing, and they can tell. I've copied and pasted before. Usually was from something that I had done earlier. I would only ever copy and paste my own note, but I got in trouble because I copied and pasted because I used the feature. It was something like, it was a part of the nursing note where it was like, because we did every 4 hours. So it would be like, for instance, let me figure out a way to say this. In the nursing note, you can create ways to create quick input text.
Yeah.
And so what would happen was, so I signed my note, and then I did my initial assessment at 8. I did my reassessment at noon, and then I do another reassessment at 4.
Yeah.
And so at 4, all I did was nothing changed, and I just copied that entire section of that note, and they talked to me about it. And they're like, you can't copy and paste. I'm like, then take the feature off, but don't ever copy and paste, especially other people's stuff, because that is going to get you in a world of trouble. Because now you are actually copying someone else's documentation, and it can be construed as falsifying documentation. And I think it's important to highlight a couple of things about EHRs and the reason this is so bad. If you have a patient that is being covered by Medicare or Medicaid, if the rules and regulations for that are so steep that you have to follow them to the exact letter of their organization, because if you don't, you're missing out on billions of dollars of reimbursement. Not only that, like, it violates the HITECH Act, which is part of the Affordable Care Act. Was it a part of the? No. HITECH was not. HITECH and HIPAA were the same. They went together. Sorry, I had to go back to my huge legislative database. But the way that works is part of HITECH is utilizing government funds for in accordance with like electronic health records. And when you start to like mess with that, there are steep penalties for the hospital. We're talking millions of dollars in penalties for the hospital. You could lose your job. And depending on the organization, if they put you on one of the larger scale background checks, you could be blacklisted. And that's a tough thing to overcome, because if they say you're non-rehirable, because that's really all they can ask, and you're like, great, now I got blacklisted from one of the biggest hospitals in the metro. Now what do? I got to go do something crazy. So it's a slippery slope. So don't copy and paste.
I don't know if you've ever run across it, but we had like an amputated something. I don't remember. And I come onto chart and I look at the last assessment and they're charting pedal pulses, all the things. And you're like, really?
Oh yeah.
Right lower extremity pedal pulse, huh? Because there is no right lower extremity, right? And you look back and see how many days, I mean, this extremity was amputated on whatever day it was. And here we are several days later in post-op recovery. And we're still documenting that this patient has a pedal pulse. Like, wow. And it's easy to do if you're copying, pasting. Don't do that.
That one is kind of it's a hot button one for me. I'm like, don't do it. Cause there's so many, like my hot button. It's easier for me to come up with like a whole list of don't do these things. And here's why, than it is for like, here are the good things you should do. So yeah, that's the copying and pasting is a huge one. So,
okay. One of your blogs, I was looking at your website and one of your blog posts specifically says, don't double document. You want to elaborate on that?
Bang my head on the wall. Oh, It killed me. I was actually teaching a class yesterday. So let me back up and talk about double documenting for a second. So double documenting is the practice of inputting data in two locations in the same document for the same time. And the reason it becomes a problem is because if the information is wrong in one spot, you potentially set yourself up for complaint, litigation, etc. I think in the blog post, the example I use is imagine you have a patient who's on like a tube feed and you put the bed at 45 because you always have your patients at 45, but then all of a sudden you document in the exact same time for another thing, all of a sudden you say that it's accidentally 15. And all of a sudden your patient aspirates, they get pneumonia, families filing lawsuits, complaints. And because they happened at the same time, you don't know, like, but people who are auditing, the people that are doing the RCAs, people that HR, legal, all these other people that are trying to basically get this family taken care of from a legal standpoint, they don't know what you did. They have to take your word. And if your word is the documentation that contradicts itself, like it's a bad practice. So when I talk about double documenting, I'm meaning if you have a place that you habitually document something and you are told by an administrator, by a leader, by another nurse that the unit standard is you document in both places, that is patently absurd. Don't do it. Mm-hmm. I'm telling you not to do it because you are going to get yourself in trouble. There's another, I don't know the specifics of it, but there's new legislation coming out that is allowing for patient transparency. I am a huge supporter of patient transparency as a patient. Mm-hmm. I also understand it from the other side in hospital administration, where if you are documenting something out of habit, you are setting yourself up for a potentially bad issue. So here's another example, and this is real. This one is real life. Let's say there's a patient that gets into their medical record on their side, on the user side, and they can read your nurse's notes. And out of habit, you say, anytime, let's say your hospital has a policy to provide your hospital policy is that you have to notify the provider when, let's say, there's a critical lab. Mm-hmm. You get a critical lab back. Let's say it's troponin. What do we know about troponin? Troponin is going to stay elevated for 24 hours. What if the lab's policy is to call you on every critical and you have troponins every 8 hours? You're going to get 3 critical values. You're going to have to notify the provider 3 different times. Mm-hmm. In a particular EHR, there is a specific location where you document critical values. There's, out of habit, some nurses have said, provider in their nursing note, critical value received, provider notified. Mm-hmm. That family member who is seeing that does not know how to interpret medical information, and now they're pissed. because they think something is very, very, very wrong with their family member, with themselves. They don't have the education or background. They're not being educated. And now you basically have to kind of do a little, you got to do some saving face and saying, this is really what this means. And you have to hope that that appeases them. And the way you avoid that is you have a location that's not available to that patient. That is for those purposes. So document there. Don't document in your nursing note, because that's not a place that should be happening. So
interesting.
Yeah, I found out about it and was like,
so, and it's live where you document it, patient receives it?
No, so well, it's not supposed to be.
Okay.
But here's the thing with technology, and this is, and I think this goes along kind of the same lines of like, never trust machines. Like, just don't. Like, always be able to, like, I'll never forget my first code. Patient was like 60/40. I'm like, that's not real, and it was. But it's that sometimes code breaks. So code is like the instructions for software or the web. Sometimes code breaks and things slip through the crack. I'm not really sure how or why a patient would receive that. Especially that feature is supposed to be turned off and everything's not like available currently, to my understanding. But if those things happen, we need to make sure that that you're protecting the patient, because it's essentially what's that is, right? So we look at patients holistically, and holistically meaning we are taking into account their family situation, their socioeconomic status, their access to healthcare. I'm looking at my patient as a whole, and that family is an extension of that patient. If I'm upsetting them because I documented something out of habit or out of the perpetuation of poor tribal knowledge is what I call it. If I do something because that's the way we've always done it, maybe we should re-examine those things and say, is that really the way we should be doing them? So if that happens, if you're ever presented with an opportunity, you're like, I documented this here and I need to document this here. The first thing you should do is stop and say, why am I documenting it in two places? And then see the ramifications of documenting one versus the other. And then find out the best place. And if you don't, then I would have conversations with your managers, maybe your the nursing governance, whoever is responsible for the documentation for that hospital. Like, start digging in and saying, why are we documenting in two places? And don't be afraid to buck the system. Like, the only thing that you are doing is you're improving efficiency, which lowers the cost of labor, and improves patient outcomes, because you're not having to worry. You don't have to stay late to do all this extra stuff. You're not creating false documents. You're not impacting the bottom line. You're improving customer service. So there are a lot of benefits to pushing back. Don't let the bureaucracy of the big hospital system weigh you down. So, yeah. I could talk about this stuff forever.
Did you cover all the don'ts?
Let's see. Okay. A couple of these are more like just pointers. Okay. Don't ever admit to an accident in a record. It's tricky, right? And this one's really, really hard, because if your patient falls, there's always going to be documentation for that. You never want to say in a record patient fell, because now what you're doing is you're basically green lighting everybody to look at your records, and you're going to let everybody in. With this particular issue, if you have an accident, an incident, harm to a patient, etc., you need to find out what your hospital's organization is for that process. But the default should never be, I walked into the patient's room and the patient had fallen. I would never document like that. I would say something to the effect, and this kind of goes into like how you should, like the narrative you should almost use. Everything is objectively. So subjective is what the patient says that they are experiencing. Objective is what you are experiencing. So if I walk into the patient's room and I knew the patient had fallen, walked into the patient's room, observed patient sitting on the floor.
Right.
That's it. And then you describe what doesn't go somewhere else there in the note. Charge notes notified, provider notified, assisted patient back into bed, completed full assessments, see wherever for details.
Mm-hmm.
Like there are ways to do it. Again, I'm not telling you what to document. I'm telling you how I would document in those situations. But yeah, admitting to faults like that, you are basically waving at the legal system to take your license away. And that's not something you ever want to do, or to have your organization under a microscope for things that can inevitably happen. It's like science. Science is not 100% ever. It's always, I mean, you can get like 99, but at the same time, you have to do things to protect yourself. Even if it means not admitting an accident. I'm not going to say not admitting fault, because there are sometimes like I've given wrong dose. It happens. Every nurse does, and if they tell you they've never given a wrong dose, they are liars. Liar, 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 pants on fire.
Yep. Errors happen. We're human.
Yeah, and that's the thing, is like there's the human element of uncertainty. So whenever we say, the one thing I'm never going to do is purposefully put myself or my organization on the line for the sake of documentation, because all I'm doing is lighting up a big neon sign, and I'm just not going to do that. The other one is, and I have not had a chance to do this, but I'm going to put the Joint Commission's updated do not use list.
Okay.
That's another one. The do not use list was originally made for handwritten notes,
Yeah.
but we still want to use the Joint Commission's do not use list, because it is the gold standard when it comes to documentation and abbreviations.
Mm-hmm.
So always making sure that you're not using like I don't even remember what's on there. Like certain leading zeros, right? So
yeah.
or trailing zeros is the one I'm thinking of. So like if you give 2 milliliters of something, you never write 2.0, because if you happen to forget your decimal point, you have now said 20.
Right.
And so like you can only have leading zeros up to a certain point. You can only have should never use trailing zeros. You should only use these documents. Like there's a list. So units is another one. Yeah. So units, always spell out units. Micrograms is another one, because it's like that's where it gets kind of in the handwriting, because when you do, it's forget whatever Greek letter that is.
That M.
It looks like a U, and so you're like, wait, what? Units? What? So yeah, when you can spell things out. But yeah, I need to get that. That's another one I need to get on there. It's been on my list of things to do, but yeah.
Yeah, when you get it on there, I'll link it in the comments here so people have quick access to it.
Yeah, perfect. Yeah, I got to get that one. That will actually be a pretty easy one to do. And then never chart in the future. Most electronic health records don't allow you to, but I drill this one when I teach. Do not ever chart in the future. Don't. The only place you could ever really do it would be in a nursing note, and inevitably, what happens if you chart in the future and something happens? Like we have a really big, the hospital I work at, we have a really, really awesome burn unit. And sure enough, they do a lot of wound care. They also do a lot of codes. So imagine being in there. I was teaching our unit techs yesterday. I said, don't say you're going to go do a bath or do your wound care, because inevitably you'll write that and you'll turn around and you'll be stuck in a room for 2 hours doing the code. Then all of a sudden, what happened to that patient's bath? And it becomes a hot mess. So don't ever chart in the future. Mm-hmm. And then kind of going back to abbreviations, don't use medical terms or abbreviations that only you know. Make sure that your hospital or organization or unit uses them commonly. There are all sorts of crazy ways to write something like D/T. If you're unfamiliar with it, it means due to. What was it? Like secondary due to. There was a specific way to write that, and I had never seen it written that way before. And so you get into the situation where you are now using language that you're siloing the communication. So don't do that. You want to create clear communication across the entire team. So that would be the only other one to avoid. So
Yeah, that's a good idea. I have to tell one funny about abbreviations. When I first started nursing, we were still writing handwritten notes. Yes, I've been a nurse that long. So we're still writing handwritten notes, and I was precepting, and it was my very first day precepting, and my preceptor had looked over my initial note, and she gave me some pointers and some guidance. Okay, great, perfect. Well, then my 12 o'clock note comes around, and I did my 12 o'clock note, and she comes in, she's coming around. I had finished, and she's like, "Are your charts up today?" I said, "Yes." So she's going over to look at my charts, and I wasn't sitting there then. I was going around, and I hear her busting out laughing, and I look over, and I'm like, "What?" So I go over to her, and I'm like, "What is happening? Why are you laughing?" And she's like, "You keep writing assessment ASS." And I was like, "Oh no." So I wrote ass on my assessment multiple times, not even thinking what I was writing. And she thought that was the funniest thing. And of course, now I can laugh about it. But as a brand new nurse, I was like, ah. But yeah. So watch your
I've caught myself doing that, and I'm just like, I need to make sure I spell this out, because if I don't, I'm gonna look like a big jerk.
Yeah.
But yeah, that's a good one.
Yeah. So, okay, we have one question that came in from Yurisa, and she said, some shifts, literally nothing happens with a patient. I work night shift, and a lot of times they take their meds and sleep the whole night. What am I supposed to write? What can I write to cover myself?
So this goes to a couple of points. What is your unit policy? What does your Nurse Practice Act say? And then also, like, if we're looking at a lot of the EHRs in general have like, think of like a big spreadsheet, and there are times and things for care that are given. If you document, let's say 10 o'clock rolls around, your patient's sleeping, and you write sleeping, and you have to round on your patient every hour. And every hour you're writing that they're sleeping, you are covering their care. If that's all you write, is that every hour you're doing sleeping. But I think her question is more like in the nursing narrative, goes into what are the policies, what are the standards, and what does your Nurse Practice Act say? If your Nurse Practice Act is basically, if they don't really provide you any guidance, the nursing narrative is, this is the actual Bob Ross picture. This is how do I paint this in a way that everybody can see what happens if it can't fit somewhere else? So if my patient is sleeping, and there's some other area that has some more details, 10 o'clock meds given, see this area for details, patient resumes sleeping, we'll continue to monitor. Like, that's appropriate, because you are saying what you are going to continue to do. You are showing that you are executing care. And there's another area where you can document that the patient is sleeping if they are sleeping. If they're sleeping and they're watching TV, or I'm sorry, if they're not sleeping and they're watching TV, and there's a place to document that, then document it, even if it's not like actual care, because what you're doing is you're giving, you're putting in the report how to, like what's really happening with the patient. And that's the point of documentation, is to follow the trajectory of care. And if all you're doing is giving meds and they're chilling, I mean, I would never write patient chilling in room, but that's literally what they're doing. So don't overthink it. There are places, I would look at your Nurse Practice Act and then go back to your organization and see what the standards are. And as long as you're following those standards, then you should be fine.
Yeah.
Outside of that, I wouldn't, because now you're getting into that. I'm now putting 15 layers of oil on my canvas, and it's going to start to look like a big blob. And I've now only complicated the communication between the team.
That's exactly what I was about to say. Don't overcomplicate it. But if your institution says to do a complete assessment every give X hours, 4 hours, 6 hours, 8 hours, 12 hours. Well, then make sure that your neuro assessment, you actually had to wake up the patient to do said neuro assessment. So make sure that you're sticking with your standards of care, whether that's your institution or your Nursing Practice Act.
Absolutely.
Yeah, exactly. Not overcomplicating. I totally agree. And if the patient is sleeping, that is, I always say appears to be sleeping, unless I actually attempted to wake them and, they said, you woke me up or whatever. That's how I liked to verbiage or use the verbiage, appears to be sleeping, vital signs stable, whatever it is. Yeah, I agree. Don't overcomplicate it. Completely agree.
I would never try to overthink that, because we feel like we have to protect ourselves, and by doing so, it's like the automatic response of, I'm going to overdo it. Like, don't just find out what those like the standards are and go with those.
Right. And maybe what side they're laying on, if they've changed from right to left, or now they're laying supine. That way, in your documentation, it's very clear. Oh, they have had their eyes on said patient, and this is what's happening. So, good question, Yuritsa, and hopefully that answers that for you. For sure. All right. Diana says, it's funny you mention D/T because they're required at their school to abbreviate due to with D/T. Not like the words due to are really elaborate and long. Sometimes I feel like we, as a profession, like to complicate things that don't need to be complicated.
There's another, I want to say, I would actually have to Google it. There's another abbreviation that's similar to that. That means
R/T related to, maybe?
DC is what I'm thinking of. Discharge, discontinue.
Yeah.
Those two, depending on their context, can mean entirely different things.
Mm-hmm.
And for instance, receive new orders for DC. If there's an order that exists at the same time for a discharge and a discontinuation of maybe a line. Let's say you're going to send a patient home and they have a PIV. And the order is discontinue the PIV and discharge the patient home. If in the narrative you say receive new orders to D/C, they don't know what you're talking about. Although I would never really probably say that in that context, because I don't need to do that. But if that's an example of, is there something discussed with provider need for DC, that would probably be something I would put in a note. But I don't know what I'm talking about because I haven't elaborated. So there are some things that exist in a narrative that could be construed. So that's why those abbreviations are very, very particular. Almost think of it like this. I type my note, I'm going to go back and read it. And is there anything that can be misconstrued as something else? So that's, I usually reread all my notes just to make sure that I covered everything. But outside of that, especially when you have weird things happen, always make sure that you articulate that very well and take the time on those, especially if it's so weird.
You know what I like to do is ask myself when I reread my note, in 5 years, will I understand what I'm trying to say here?
Yeah. Because
if you're not painting that picture well, then all of a sudden you're like, I don't know. So because you're not going to remember, just expect that you're not going to remember. You've taken care of hundreds of patients in this time frame. You're not going to remember. There are very few patients that I can personally say that I distinctly remember. And if you ask me about a specific occasion, those memories you cannot put any weight in those. Right. But read back your note. In 5 years, will I understand how this sequentially happened and what I did?
Right. For sure.
That's important.
Yeah, for sure.
All right. So this was all really great information. You guys go look at his website, mynursingnote.com. There's a lot of good information there. Your Nursing Practice Act is easy to access there. Good news articles on the pros and the cons. Nurses documenting well, nurses not documenting so well. I just feel like it's really insightful to see how we're being portrayed in the news, and you might learn something. Honestly, I was thumbing through there and looking at those news articles. I think that's really super interesting. So in closing, Chance, let's talk about what you're most looking forward to in your career.
Man, it's so weird, right? Just like thinking long term. I think that I love the diversity of nursing. In that I don't quite know what to anticipate in my career. I know that there are certain things that I really love doing, like building tech and teaching. And as long as I can kind of like scratch both of those itches at the same time, then I think that I will be happy with my career and the way it's going. If I get stuck, like I was actually kind of a little bit apprehensive. I had to do some career changes kind of earlier this year, and I was a little bit apprehensive about going. There was a question I was going to go back to bedside, and I hadn't done it in a while. And so, like, I know that's always something that it's like riding a bike. I can get in there and do it.
Yeah.
But I do think that, like, I will best serve the nursing profession, the hospital, my family, and myself if I am able to do things that I continue to be passionate about. Not saying those things won't change, because I didn't even know, like, for me, like, building websites was actually fun. I was like, oh, I really like doing this, and just kind of trying to get in the head of like users, because I have no idea, like, when people go to the website, what they like and what they don't like. And so, like, spending time in like Google Analytics and those kind of things is really a lot of fun. And then, like, designing curriculum is always something that I've really enjoyed, and so, like, I get to do that every day at work. So that's a lot of fun. So as long as I get to do those things, I think that's really where I'm going to be happy.
That's awesome. And that just really speaks to that. Our industry is so vast and there's so many options. If you're listening and you feel like, I don't know if bedside nursing is for me, that's okay. We need you. Stick around. There's a place for you. Reach out to one of us. Like Chance and we have a lot of experience in various areas. Reach out to us. Tell us what you love, what you dislike. We can throw some options out there and see what might stick. So in our last question for you is, if anyone's listening today and you could take away one thing from our discussion, what would it be?
One thing. Oh, man. I'm going to go to the Bob Ross analogy because I think it can kind of really set people up to be successful with just like documentation in general. And documentation is an extension of charting. There was a study done recently that people were like, oh, people don't spend that much time charting. This is what the authors of the article said. They said they don't spend much time charting. They spend about 15% of their day charting. I'm like, that's 2 hours in a day charting. That's a lot of time charting. It sucks. If you can think about your documentation as, I need to create a clear communication and a big picture for the entire team without creating confusing things and working within the confines of the tool that I'm using, whatever electronic health record I have, I'm going to improve my efficiency. I'm going to improve my patient outcomes. And I'm not going to be stressed out that I have to spend 15, can't tell you how many shifts that I had where I was like, all right, I just gave a report. Now I got to go spend another 30 minutes charting.
Yeah.
Sucks. But spending the time to kind of think about the context of what you do when you chart and you document anything is always extremely helpful.
I love it. Well, thank you so much for joining us. Thank you for the time you're putting into educating us as a profession about charting and systems, and just making that aspect of, it's a critical role in our job, but let's make it more of a system and less of a chore. I love that. So to all of you who are listening and tuning in, thank you for being the tribe, empowering each other, learning together, laughing together, and supporting one another. Never stop learning. Take care, guys. See ya.
See ya.